Okay, Dr. Vijay Varghya, we are live. You can
Hi.
submit the case. Yeah.
Good evening, everyone. Welcome to Department of Cardiology, PGI Chandigarh. It's a pleasure and honor to be there for NICCSI to present the case. I'm thankful to the organizer, Dr. Bali, Dr. Chandra, and the team for the invitation. So before going ahead, let me introduce my team. I do have Basant Kumar, additional professor from the Department of Cardiology. I do have Anirudh, Mayank, and Arkit, senior resident from cardiology. Anand is a technician, and Nikhil is there on the OCT. So before going ahead, let me request Dr. Basan to present the case, please.
So thank you, sir. So here we have a case. Slide, please. Yeah. 68-year-old diabetic hypertensive male. He is morbid obese. He presented with us with a stable angina class 3 last 6 months. The clinical examination were unremarkable. And BMI is 37.9 kg per meter square. His parameters like hemoglobin is 12.8 gram, creatinine is 1.02, and EGFR is 73 ml per meter, 1.73 meter square. So sugar was under control with insulin and OHA. The total cholesterol is 209, and HDL is 39, LDL is 140, and TG is 149. He is on atorvastatin 40 milligram. ECG was showing left anterior fascicular block, otherwise it's normal. Next class, yeah. So four chamber view, you can see that the ejection fraction is normal, 60%. There is no RWM in two chamber view and four chamber view. Next. Yeah, so we did angiogram. You can see the left main is fairly normal. Ostial LCX is significant lesion, around 90%. Angle is 74 degree. And the distal LAD is significant lesion, about 80%. RCA is normal and it is dominant vessel. So the plan is the PCI of the left main bifurcation under the image guided. Sir.
So we have taken the transfemoral 7F assess. It's a JL7F guide. And next view, please. So this is about the distal LAD, which is significantly diseased. Mid LAD is also having some disease. Previous view, please. Okay, this one. Proximal LAD is fine. And then there is a ostial LCA, which is tightly stenosed. Next. So basically, it's a left main which seems to be normal. Proximal LAD is okay, and it's the ostial LCA disease along with mid to distal LAD. So how to proceed? Any comment, or should I proceed further?
The proximal LAD is tubular disease.
Yeah,
you will find it on intravascular ultrasound, I'm sure.
Okay.
The left, the circumflex is a very large caliber artery, and you can tell immediately that your left main is heavily diseased, and it would have a very high plaque burden. And so also your proximal and mid LAD. So show us the intravascular or OCT imaging.
Okay.
Whichever you're doing.
That's good. Yeah. So next you please. And we wired the LCA with a BMW and FFR wire across the LAD. Next you. For that, just hold on. And can you show the CMD across the LAD? So we have placed a wire across the distal LAD to look for IMR and CFR. So can somebody demonstrate the CFR and IMR value on the screen, please? Yeah, this is what. So we do have a CFR of 2.3, IMR of 33, and the distal LAD has a FFR of how much? 0.79. It's a 0.79, and next on the pullback we had an FFR across the proximal LAD, which is how much? 0.93, 0.92. So this is what the functional assessment across the LAD, for which next view please. We have next view please. We have dilated the distal LAD with 2.5 millimeter balloon. Next please. And then here we are. So any comment for the distal LAD, the reference vessel for the distal LAD, and then we had an OCT also done across the LAD. Can you demonstrate the OCT?
Are you considering DABE or stenting?
So the vessel distal reference diameter is around 2.25, for which we have inflated the distal LAD with the 2.530 drug-eluting balloon, sirolimus drug-eluting balloon across. Next view, please.
Yeah.
This is the OCT run which we
It
have
looks to
taken.
be good, yeah.
Next. And this is the regulating balloon across the distal LAD. So it's a 2.5 30s solution sirolimus eluting balloon. Next. And this is what the result across the distal LAD after regulating balloon. Next. For the mid LAD, there was the MSA. Can you demonstrate the MSA across the mid LAD, which was around 2.62 in a vessel of around 3 millimeters? So we have deployed 338 millimeter stent across the mid LAD. Next view, please. Was dilated with 3.5. Next view, please. So this is what we have achieved. So it's a mid LAD 338, post dilated with 3.5. Distal LAD, it's a regulating balloon 2.5 30, and can you go to next? And this is the LCX. Just stop. Why are you moving? Just stop. So we have done the LAD part over here, and the proximal LAD, the FFR is 0.92, which is functionally not significant. And then this is about the LCX. Next view, please.
So what is your
LAD
plan
result.
now?
So that's what. Here we are. You kindly suggest how to proceed for the ostial LCX. Next view. Just hold on.
What balloon is this?
So we have dilated the ostial LCX with a 3 millimeter NC. Next. This is what the result is.
Can you do an imaging of the LCX?
Next, you please. So we have done the imaging after 3 millimeter NC balloon. Can you demonstrate the first LCX run? Can you? So we have a reference of 4 plus the proximal LCX, and the minimum luminal area across the ostial LCX is how much? 1.5, 3.2 after having a balloon dilatation with a 3 millimeter NC balloon. Next, you please. Yes, please.
You're going to do some more balloon dilatation.
Absolutely right.
I would take a 3.5 millimeter Wolverine.
So this is a 3.515 cutting balloon across the LCX. Next.
Yeah.
This is the result across the LCX after 3.5 cutting balloon. Next. And this is the 4 millimeter NC balloon across the LCX. Next. Next. And this is the result after having a balloon dilatation across the ostial LCX. Next. Clear image. So now the question is how to proceed further. Do you want me to go ahead for a drug-eluting balloon or drug-eluting stent across it? Any comment from the chair?
Can you show us the imaging of the left main? I mean, you are doing OCT, so I appreciate that you won't be able to show the whole of it.
The left main OCT. Oh, okay. Yes. This is the left main, which is having the reference diameter of 5.2. How much? 5.12. And this is left main. The area is how much? 9.7.9 plus across the left.
Yeah. Okay. I don't think you need to do anything there.
Okay.
Now, since you're dealing with the ostium of the circumflex, and if you are happy with the lumen gain in the ostium of the circumflex, then it is best to do a DEB, because there will be some carina shift if you stent it, and you might.
We have an angle across LAD and LCX of 74 on angiography, which is okay, but then absolutely right, there is a risk of the carinal shift across the ostial LAD after having, but then we had now, next view please. So this is the OCT after having a 4 millimeter NC balloon dilatation across the LCX. And can you demonstrate the OCT across the LCX? So we do have a residual stenosis across the ostium of around 50%. Ideally, if we want to go ahead with the drug-eluting balloon, it should be less than 30. There is a significant residual stenosis despite having a balloon dilatation with 4 millimeter NC balloon. And in case we are going to use the drug-eluting balloon, it's going to be say 4 millimeter only. And therefore, with a result which is not so satisfactory, though the MLA is around 6, minimum luminal area is 6.35 across the ostial LCX. Next view, please. Run next view.
Just run it slowly. Run it slowly over the tightest width, the OCT. You're stenting. Okay. We would have.
Okay. Can you run the OCT, please? The OCT left main to LCX.
That tightest bit. Can you just just run it slowly over here. Okay.
This is the Lackman. Can you demonstrate the LCX ostium?
I don't think there was any significant dissection there. Little bit, and I think the lumen was. I agree that it is less than, it is like 50%, but residual, but the lumen gain was significant. And yes. Stent. So if you stretch that out a little bit more, and end up with like something like near to 7. But obviously I've seen that you're stenting. So
this is what the angiographically across the left main bifurcation in the spider view, we show a significant ostial LCA disease and also the distal left main. This is after say 4 millimeter NC balloon dilatation with this significant lesion across the left main bifurcation and also the ostial LCX. We decided to go ahead for the stenting across left main to LCX. Next,
I think that's a reasonable thinking, and I too totally agree with you.
And you will have to now address the LAD as well. I'm sure you will want to do an FFR again.
To be disease.
So
if it happens, we'll have to go for stenting the proximal LAD.
Yeah, absolutely. I mean, stenting is
osteoproximal LAD.
Yeah. Stenting
so now what we have done is the left main to LCX 4 into 23 millimeter stent. Next.
What stent you have given?
It's a evolution stent. From the Abbott vascular.
I'm asking.
So
sorry.
Then we'll talk. Complete the stenting first.
Next. So it's a 4 into 23 evolution stent from left main to LCX. Next. And then we had a post dilatation with the 4 across the proximal LCX and port with the 5. Next. This is the result after the post dilatation. Next. This is what the result is. Any comment now about the LAD?
The circumflex looks as good as it can, and the LAD certainly looks like there is some carina shift, and there is like angiographically at least there is a 60 to 70% stenosis at the ostium.
Yeah,
right.
LAD was diseased already, and there is some plug shift, and so it looks to be dealt with. It needs something to be done to the osteoproximal LAD. Next view, please.
So this is the spider view. Next view, please. Next. So next view. So here we are across the rewiring of the LAD from the standard. Next view, please. Next. And then we had a dilated. Next view, please. This is 2.5 millimeter balloon across left main to LAD. Next view, please. And this is what we are over here. So this is at present we are waiting for you to comment about how much is the LAD and how to proceed further.
I think you will have to do something to the LAD. We are all agreed in the panel on that. We will leave you for a while and go back to Apollo, and we'll come back and see your final result. Okay?
So let me go ahead, do the functional assessment of the proximal LAD and then decide about whether to go ahead for any stenting across it or not.
Sure.
Fine. Thank you. So what we have done the FFR across the LED after having dilated with 2.5, and then can somebody show the FFR value across the LED?
Okay.
So it's a 0.79. We have now dilated with the 3 millimeter balloon across the LED, and this is the angiographic result. Any comment?
You have to stent it, no?
Okay. It's a 3.5 per 18.
18.
So which is strategy? 3.5 18.
Yeah.
So what we are planning to go ahead with the tap technique, it's a 3.5 18 across the ostial LED. We have already stented the left main to LCX. Is it okay? Any comment about?
Can you show us the caudal view
Okay,
as you
okay.
are stenting, so we get a better idea of
Fine.
where you're going to position your stent?
Let me show it.
Yeah.
I'm having some difficulty, so let me dilate it with say 3.5 NC and then proceed for.
Yeah. Is the angle on that circ, that bend there, that is causing you a little difficulty?
3.5. And meanwhile, give the spider view, please.
3.5 NC.
What is this 10, Dr. Vijay Borgi?
It's at 3.5 18 volume oscillating stand from
Okay.
Abbott.
Okay, okay.
What's the size of the balloon, sir?
It's at 3.5 now. This is 3.5. Inflate. 18.
18.
Negative. Inflate. 18.
18.
So we have dilated negative.
Go up all the way. We can't see the balloon very well. I hope you have gone up
Okay,
all
it's
the
a
way.
spider view, obese vision, and therefore epicaudal.
Okay. So you went up to what pressures? 20?
20.
No, it's 18.
20. 20.
20.
Yeah. Your stent
Stent.
should go now. Yeah, epicaudal is better. We can't see anything.
Stent.
So this is what we are with the 3.5 balloon dilatation. Basi bas.
You can take the circ wire out and try.
Okay.
Better to put a second body wire here.
No.
Allow yourself a little better.
एक दे गाइडलाइन दे.
I think, Dr. Vijay Borgi, if you take the sarc wire out and put it inside the LED.
Actually, I don't want to lose the lumen of the LCS at this point of time.
Dilated, the stent is there. I don't think there will be any problem in
Okay,
getting
okay.
it.
Let me have the.
We can take
Actually,
another wire.
the thing is, it's a normal JL guide. In case it would have been EBU, it would have been easy for me to go ahead and put the stent across. So,
You don't have enough support.
let me have the guideliner over here to have the support and then go ahead for. So, hopefully with the guideliner, I will be able to push it.
If you can push the guideliner through the stent strap, then you're through. Yeah, true. I think if you take the sarcoma out, it will solve your problem.
So what is the guideliner you are using?
It's a 6F. I think I will be able to lower it.
Stent.
No.
I think the issue is about an alignment. You can take the LCX wire out and align the guiding with an LED.
Okay, let me try it.
Yeah, I feel it is all about alignment because you're
Okay,
good dilatation.
okay, that's what. Let me remove.
I think balloon assisted guideliner to be advanced to the LED. Otherwise, it can be a demise. I think take a balloon over this guideliner to the LED and inflate the balloon and over that track it.
You could try what Dr. Mandal said. Take a balloon through that guideline.
Please take a balloon and you have a stent in the LED and go up to that and inflate that
Give
balloon there.
3.5
Yes,
balloon.
over the flag that is guideline. Otherwise, it will not go.
Right. I got your point. Let me inflate the balloon across the LED. 3.5 balloon.
I feel the guideliner with the Nipro is better. They have got a better trackability as compared to the other companies. Because they have
Now see whether your guideliner will go or not.
8,
Just 10,
10, 12.
12.
I am having some difficulty across the ostium. So maybe.
Pull the balloon back and go to 24. Across that stent strap.
I think.
You have to make yourself a little more space.
Inflate. Let me dilate the left main over here.
40.
Negative.
Go up.
And possibly now I will be able to push it. Yes.
Yes. Okay.
Instant.
Stent.
Instant.
Go with the stent up to the mid LED, then bring back. Otherwise, it will can drop everything.
Yeah.
Yes, you are right. So here we are out from the guideline. Can you have the double mag, please?
Yes.
And send a test another.
Yes.
Okay.
Please do one senior. Otherwise, if you come back too much, you cannot push again.
Yeah, this is what. So here, let me go ahead and put a wire across the LCX as well at this moment of time.
Yeah. Okay.
Test the introduction.
Yes.
Yes, we are across the LCX.
You have come back a little bit.
Right, you are right. So,
Yeah.
This seems to be okay. Spider view.
A spider, we can't see anything. I think maybe probably. Yeah, let's see on Cine.
This seems to be okay. What do you say? Should I pull it somewhat more?
I think one more.
It's okay. You can see.
It's okay. It's a double mag. Double mag? Stop.
Stent boost? Any stent boost?
Stand boost. Can you put the stand boost, please?
Yeah, we will. Let's let them finish.
दिखाओ. Inflate of
6, 8, 10,
12.
12.
It can.
Negative. Epicaudal. Inflate of
6, 8, 10, 12.
Negative.
It's well into that circ stent. Okay.
Look now.
So if you can give us one shot, we'll have to go to the other lab.
Okay. Just hold. Let me show you. So this is what the result is, and let me go ahead for say
Yeah, it looks good.
final kissing followed by pot.
Why was the gel your first choice?
Why did you choose gel instead of
Because you can support in this patient.
extra backup?
Yes, that's a good question. Actually, we should have used EBU, but then with the left main stenting, ostial stenting, we are more comfortable with the JL to have now OCT across the ostium, and therefore we choose over here to have now.
But with an experience of Dr. Rajesh sir, I feel you can easily handle the ABO in such scenario.
Yes, you are right, but I thought let's have the good imaging of the ostium of the left main, and therefore I prefer to have now JL instead of EBU. So let's go ahead for the final kissing, 3.5 across the LAD and 4 across the
SAR.
LCX.
Yep.
And let me reposition my L6 wire properly over here.
3.5 LED. 3.5 LED.
3.5 LED, right. Please.
Kiss.
So this is 3.5 and 4 across the L6, please. So this is what we are with the 3.5 across the LAD and 4 across the LCX. Inflate 1. Inflate
1.
8, 10, 12, 15, 18. So it's LCX negative. And now the LAD 18, 18, negative, 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 and inflate 12. So this is 3.5 and 4 kissing balloon across the left main bifurcation negative.
Excellent.
And now it's the pot followed by final image. And this is what the result is across the left main bifurcation. Any comment?
It's a very good result. So you'd like to see a final shoot after the pot.
Okay, okay. So this is somewhat in the LCX. Let me pull it back. This is okay. Inflate.
6, 8, 10, 12.
Negative. Inflate. Stand boost. 8, 10,
10,
12, 15.
15.
Negative. Stand boost.
What was the size of the balloon, Dr.
It's a
Rajesh?
5 millimeter.
Okay.
And
okay,
then this
fine.
is what we have dilated appropriately across the ostium. Epicaudal. So this is final result across the left main epicranial. We do a good flow across the distal LAD, which has been
It's
treated with
very
the
well
regulating
done.
balloon
Yeah.
and spider view last view. This is what the spider view is.
Yeah. So it's very good result. Give a big hand to Dr. Rajesh Vijay and his full team. Thank you, Professor Vijay for showing a beautiful case. It was a very difficult case, but very well done by you and your team. So thanks a lot. Give a very big hand. And
It's
we have
always an
to
honor to
stop
be there with the
transmission.
NIC.